Hello, this is Sean Dolly. I'm Cloudera's industry leader for health and life science. And today I'd like to talk about how Cloudera has helped health plans leverage big data. So Cloudera is widely seen as the largest company that's focused exclusively on providing big data technology. And over 80 organizations worldwide subscribe to Cloudera's support and software distributions for open source big data technology. We're excited, and I'm excited about the customer base. The majority of lives in the US are covered by organizations that use Cloudera, and we have health plans on 4 continents and an absolute wide variety of use cases in use at these health plans. So it's been an absolute pleasure, and I thank all the health plan customers that we have for using our technology to help improve human health. One of the most frequent questions that we receive is about what use cases are most common in our health plan community. But taken together, these are the most common use cases that we see for big data at a health plan. I'd like to continue by walking through a customer case that was successful on Cloudera. This one happens to be in that area of post-adjudication payment integrity, and in this case it was about getting a more rigorous and data-based approach to predicting clinical events around opioids as well as drug or prescription seeking behavior. So this was a very large health plan that also provided health services to members, and you'll be able to see in this use case that it was very clear big data was the right technology to use. So this was the goal. The goal here, whether you call it mashing up data for investigation, whether you call it data science, whether it was pattern recognition and drug seeking, you can see here the goal of the program. So this program was, can we understand the prescribers that were abusing the system, the pharmacies that may have unwittingly been part of a system of abuse? Can we understand members who are trying to take advantage of the system? And as well, on a clinical side, how can we predict who is going to have an overdose and how can we act accordingly? Now, without that data and without that rigor, but historically, the health plan had some sense of the kind of behaviors that are end well clinically, and those that ended up with an overdose or ended up being a situation where someone was drug seeking. In the first case you see here, these are folks that are understandably, because travel takes time and financial investment, they wanted to travel relatively low distances to get to their physicians and their pharmacies. These were short-term uses of the drugs, or over time the dosages were decreasing, and ideally there was 1 or 2 doctors and 1 pharmacy that were filling the prescriptions. On the other hand, when it was clear that there was drug seeking, oftentimes you may have prolonged use of the drugs or increasing use, certainly as a precursor to overdose. These folks were willing to travel long distances, and as you can imagine, that requires geographic information, from understanding distances from a member's home address to their physician or their pharmacy. These were folks that were using multiple of doctors or pharmacies or both, refills on the same day or many days of overlap across similar prescriptions, kind of thing. So the patterns weren't limited to just one variable. They were multivariate and needed multiple different data sources. So more on that last point, on the challenges that they had as they approached this desire to get more rigor. They realized they needed data that was in multiple sources that, for whatever reason in the past at this health plan, had not been integrated before. And so without an existing data lake, if you will, that had all the ingredients, that was a challenge for them. The other is, as you'll see in some statistics shortly, the scale of this data set was prohibitive. And even if they honed it down to a relatively small geographic region, it was still quite a scale, and that can provide challenges both in the response time of any analytic as well as the funding involved to get it together. They also did not have a sense of where the audience questions would go, and so they wanted to provide a system or an approach where someone could ask any follow-on question, but they didn't find a real clarity around what those questions would be until they started putting information in front of the folks using it. And as a result, the traditional approach of going out, gathering requirements of what questions will be asked, taking the time of developing a schema for the data that would perform well for those questions just wasn't possible. And so they needed some approach that wasn't writing my schema in advance and then writing, if you will, the data to that structure, but rather they needed some approach to apply a schema after questions were asked. They also found out from IT that these data sources were changing. Not only were the data sources changing, their structure was changing, and so anything they built or wrote could change if they had a schema, so if they had a hard-coded model. The user groups were different, as you recall. One was about payment integrity, the other was about clinical. So whatever user interfaces or approaches they had on the analytics side, they had to have a technology that could allow for multiple different access paths. It was multivariate, as we talked about, and it wanted to be predictive. So we were in the realm of data science at this point. And then lastly, they had a lack of previous studies and specific evidence that would allow them to use hypotheses that were based in data. And as a result of that, they had to have a wide ability to code different models and try different things to find some evidence. So not a trivial amount of challenge here around this. And so they opted to leverage Cloudera technology, and on the left you can see on the slide some information about the kinds of data that they brought in to do this, that they used the business intelligence software from Tableau to visualize the information, that they had a scoring algorithm to rank risk of multiple parties involved, and it was successful. Now usually folks are interested in seeing the information that's on the right, and you can see the absolute scale of this in their claims data. They had more than 40 million encounters for this relatively tight geographic region, many diagnoses in that data. They had meta information about 3 million prescriptions, over 500,000 patients, well over 100 pharmacies were involved, GIS metadata. I'm sure there was even other data that isn't listed here. And they easily were able to create a data lake with that information because they could bring it in its native form without applying a schema and without doing a lot. So you can see the results here of some of the analytics, just a very wide list, and without reading it, just a wonderful mapping user interface with heat maps. They were able to find most wanted members or providers that were likely committing fraud, could look at drugs that were indicative or predictive, other behavior, just absolutely. And because the information was in the data lake, it would be easier with the big data technology to move it to other kinds of user interfaces. So this is just one example of the tens and tens and probably hundreds of successful use cases that we have in our health plan community. So with that, let me just say that we do believe, and I have seen every day, that folks that want to be HIPAA compliant and stand up big data, hardened environments that are super fast, easy to administer, very secure, have been very successful with Cloudera doing that, and I think most successful with Cloudera doing that, and I'm proud to be a part of it. Just a little bit about me. Feel free to send me an email if you have questions at sdolly@cloudera.com. And then, why am I doing this? And you can too. I'm doing it to make a difference in public health and human health. and I try to do that every day, and I'm happy that Cloudera gives a forum for me and for our customers to do that as well. So with that, thank you very much.